many other places.
Yikes.
Not really.
To watch for that.
Right.
Let's see. Okay, well, it looks like it is 12 noon. Thank you for kicking off what we were going to do to start to welcome everybody. So welcome and hello to everybody from CMDA. We welcome you to today's monthly meeting on December 5th. I just wanted to start off with some announcements. My name is Singh Pallet, the president of CMDA. And hello, everybody. We want to remind you that Geriatric Grand Rounds is in 2 days, 7:30 in the morning on Thursday, December 7th. And CMDA member Dr. Hilary Lum will be presenting at that time. December 12th, CHCA is having a psychiatric medication management training, and we have several members of CMDA presenting on that, including Dr. Leslie Eber, Jenny Albertson, Jessica LeClaire, and Samantha Ward. In January, I'm telling you now, but I will send an email later, we're not going to have a CMDA monthly meeting. It runs right with New Year's holiday. So you can expect that, because that means our next meeting will be in February, on February 6th. And since we were just talking about it with everyone here who was joining on early, the AMDA National Conference is in March in San Antonio this year. They are accepting registration right now. So please get on to the website, get your travel arrangements made, and we'll see you at that annual conference. And if for some reason you can't make it to the national conference, don't forget that CMDA is having our annual conference right here in Denver on April 19th. And so we invite you to join that. And thank you, Jenny, for giving a little more information about the psychiatric med management training. Oh, and that it's going to be on a live webinar too. That's really exciting. Thank you so much for making us aware of that and for inviting CMDA. So we have a really great agenda today. And the first speaker, I'm going to go ahead and let him start. Mr. Alan Horowitz is of counsel at Arnall, Golden, and Gregory. And he is here today to talk to us about medical aid in dying, medical, legal, and ethical issues.
Thank you very much, Singh. Can everybody see the slide that I just presented?
Yes.
Okay, great.
You might want to put it into slideshow. Yep, at the top. If you go on the top and scroll over to the right, it says slideshow right after the word animations.
Farther up, go up.
A little further up. You go. And
from the beginning.
From the beginning.
Okay.
The beginning.
Great. Sorry for that delay. At any rate, it is a privilege to speak to you folks. Again, I'm honored. And in the next 25 minutes, I want to talk about medical aid in dying. As I'm sure all of you know, Colorado has acknowledged this legally. Let me also start by saying there are no ethical conflicts. I have no financial interest one way or the other. And the purpose of my presentation is purely educational. I'm not providing legal advice. I'm not supporting or condemning the concept. I think there are two sides to the issue, and both are worthy of being respected. I will talk about two legal cases from two different states where the courts came down differently, dealing with the physician's right and the patient's right to medical aid in dying. I'm sure everyone is familiar with some of the bioethical principles that govern your practice in one way or another: autonomy, beneficence, non-malfeasance, and justice. And these come into play. I mentioned earlier, I'm always fascinated, even though I'm not a physician, I'm fascinated by the intersection of medicine, law, and ethics. And I think there are few areas that highlight the intersection of law, medicine, and ethics as much as MAID. Just briefly, going through some of the opposition, some of the support. Many of the people in organizations, including the AMA and including AMDA, and we'll talk about that in a minute, that are opposed to MAID feel that it's unnecessary so long as you can provide adequate palliative care. going back to the bioethical concept of non-malfeasance, some physicians and others feel that contradicts the concept of non-malfeasance. It interferes with the sanctity of life. A physician's job is not to assist in ending a patient's life. Rather, it is contrary to the Hippocratic oath, or first do no harm. And it also, some of the opposition has articulated, well, it could be a slippery slope. This could lead to further forms of ending a patient's life, whether it's euthanasia. And by the way, there are instances where even in the medical and legal literature, MAID, medical aid in dying, is referred to physician-assisted suicide. It is not, I would argue, it is not physician-assisted suicide. That's very different. But that's what Dr. Kevorkian was engaged in a number of years ago. Again, many medical societies oppose MAID, including, as I said, AMDA and AMA. My understanding is that AMDA may be revisiting its policy, and we'll see that in a few minutes. I'm looking at, I hope you can see the slide clearly. I'm looking at a box with photos of.
We're looking at the opposition and support for MAID.
Okay, if you can see that, great. My apology. There's a box that's showing the people that are in attendance, which is interfering, but I'll just minimize that. So again, forgive me. In support of MAID, many people feel that it is indeed an act of compassion, and primarily it's recognizing a patient's autonomy, the individual rights as opposed to those of the state. Some physicians have articulated that it is the physician or the advanced practitioner's job to walk with the patient wherever that takes them. It alleviates unnecessary suffering, particularly for someone who's at the very end stages of a terminal disease, who may have intractable pain. Others feel that, well, this has always been done, just not publicly, and it's been done quietly. And there's an argument to be made for honesty and transparency. When I started researching this topic a year ago on Carl Steinberg, and I did a presentation, I saw this policy from AMDA from 1997, and basically AMDA opposes physician involvement in what AMDA at the time referred to as assisted suicide or active euthanasia. Again, I would argue from a purely technical, a legal perspective, it is not, and no disrespect, but we've learned a lot in the last 25 years, but I think there's a distinction between assisted suicide, where a physician or someone has a very active role in ending someone's life, as in hands-on or active euthanasia, and MAID. At any rate, I suspect that AMDA will be re-examining its position statement. The list of organizations for and against it are way too long for me to list in any one slide. Many organizations that have been historically opposed to MAID are moving to a position of quote unquote studied neutrality. So for example, the American Academy of Hospice and Palliative Medicine, their position now is one of studied neutrality. My understanding is that while the AMA is opposed to MAID, some of the state chapters have moved to a position of studied neutrality. So we're seeing a shift in attitudes in the medical profession and in fact in the legal profession. There are currently 11 jurisdictions where MAID is legal. Obviously, I've highlighted Colorado's, and in Colorado, our state legislature enacted the End of Life Options Act in 2016. So for the last 7 years, MAID has been legal in Colorado. There are about 14 states that are currently considering legislation. I suspect the list will grow. And by the way, just as an aside, not every state has the same exact approach. So for example, while almost every state but one has a residency requirement, Oregon no longer requires an individual to be a resident. So a patient who's seeking MAID and lives in one of the states where it's not legal can go to Oregon and they're automatically a resident, and they can, the very next day they can request MAID. I mentioned there are two cases that I want to talk about, and I'll go through these quickly. And I should say that if we run out of time and anybody has any questions, I will be available. I mean, feel free to email me any questions. I will do my best to answer them. The first case I want to talk about is Judith Dale. Judith Dale was diagnosed with inoperable stage 4 colorectal cancer with mets to both her liver and lungs. She entered a hospital in May of 2016 in California. It was the University of California Medical Center in San Francisco. A month later, California passed the End of Life Options Act, which became effective June 9th, as I said, the following month, which allowed for a patient, an adult patient with a terminal illness, to request a drug prescription, a lethal drug prescription from their physician. Mrs. Dale met all of the requirements under California law for MAID. While she was a patient, she was told or led to believe that she would be provided with a lethal prescription to end her life. She had watched her mother suffer in her last days from a form of cancer that ravaged her, and she absolutely did not want to die the same way. There was no question that she was terminal, given her metastatic carcinoma. The medical records indicated that there were conversations with the physicians, the social workers, and the staff at the University of California, San Francisco, where Mrs. Dale indicated what she wanted. She was discharged, then readmitted from June 28th to August the 6th of 2016. Medical records revealed that the palliative care team had a note where Mrs. Dale was, quote, very motivated to pursue end-of-life options. At one point, when she's being discharged on August the 18th, she learns from her physician, the oncologist, and other members of the staff that they're not going to help her, in spite of the fact that she had numerous conversations while she was both an inpatient and outpatient, that they would in fact support her decision to end her life, consistent with California law. The University of California, San Francisco Symptom Management Services team promises on their website material, this is publicly available, quote, your social worker will assist you in finding a doctor who has agreed to participate in the act, the End of Life Options Act. The complaint that's ultimately filed in court on behalf of the family of Mrs. Dale says, well, that's false advertising. You're saying your medical center would do this, and you did the exact opposite with our mother. When she was finally informed that the University of California Medical Center would not assist, it was too late, given a timeline to have a second notification from a second physician for her to have medical aid in dying. And she died, according to the complaint, a horrible death. In fact, this is language that was taken from the complaint that the family filed in court. And after her diagnosis, the complaint alleges that Mrs. Dale clearly and repeatedly requested aid in dying under California's law, and the defendants, which would be the physicians, social worker, they were named, as well as the medical center. And the complaint goes on to say that she would not have started treatment unless they would respect and facilitate her right to MAID. The complaint goes on to quote, defendants repeatedly agreed to respect and assist her request for aid in dying. Documentation evidences multiple conversations with physician, social worker, and other staff. Ultimately, they didn't. Part of the complaint alleges that Mrs. Dale's wish for peaceful death through aid in dying was denied by the decision of the defendants. The uppercase letters are in the court pleading, not mine, not to participate in end of life. With knowledge of the serious harm this would cause her, Judy's final weeks were brutal. She did not want to die in a diaper, bleeding from her rectum and urinary tract, in pain, unless sedated to the point where she was too confused to say goodbye to her family. But this horrific death was forced upon her by defendant's action. That was taken right out of the complaint. The complaint against the physician, the social workers, everyone involved, and certainly the medical center, alleged 5 causes of action: elder abuse under California's elder abuse statute, neglect, misrepresentation, fraud, negligent infliction of emotional distress, negligence, and survivorship. The plaintiffs, the family of Mrs. Dale, sought not only general damages and special damages, attorney's fees and costs, but also punitive damages. The case settled, and ultimately, I think the takeaway from the Dale case is that if an institution is going to tell and document a patient, we support this, we support your right, it would be incumbent to follow through with that and not change your mind, especially when it's too late for the patient to find a healthcare provider who could cooperate. So again, I think that's the takeaway. There's another interesting case out of Massachusetts dealing with two physicians. Dr. Steinbeck was a physician who treated terminally ill patients and was willing to write prescriptions for a lethal dose of medicine for someone who was competent and terminally ill and an adult, so that that person could self-administer the lethal dose. And in order to find out if this was going to be legally acceptable or not, Dr. Steinbeck and a patient of his who happened to be a physician, Dr. Dr. Kliegler, petitioned the court to see if this was constitutional. So the case goes to trial in Massachusetts. It ultimately ends up before the Supreme Judicial Court, which is the highest court in Massachusetts. The issue is whether or not a physician can be criminally prosecuted for manslaughter for prescribing medication used by a competent terminally ill adult. And the secondary issue is whether a competent terminally ill adult has a right to end their life with a lethal prescription. For better or worse, the case was decided almost a year ago, last December, and the Supreme Judicial Court in Massachusetts rejected the concept of MAID. What the court said, and again, this is the highest court in the state of Massachusetts, the court held that there's no constitutional right to MAID. Again, very different than the way Colorado and California and 9 other states have viewed this. And they said that, in fact, it is specifically prohibited by Massachusetts state law for either a patient to request this and essentially give themselves a lethal dose, and for a physician to provide a lethal dose. So you can see the wide divergent approaches between, in this instance, Massachusetts and California. I'll go through this quickly. Dr. Kliegler, was a legally competent physician. He had incurable stage 4 metastatic prostate cancer, and as I indicated, he wanted a lethal dose of medication. Dr. Steinbeck was willing to provide it. They both go to court to find out if they can, and as I said, the court disagrees and says there's no fundamental right, and the court unfortunately referred to this as physician-assisted suicide. The court went on to say such a right finds no support in our history, in our evolving traditions, and our understandings of equality and fairness, or in our judicial precedent. One of the justices of the Supreme Court in Massachusetts said physician-assisted suicide is quintessentially a legislative matter, and there's wisdom in that. Oftentimes courts will say, look, we don't want to get involved with these medical, legal, ethical issues. Let the state legislature do that, which is exactly what Colorado did and the 10 other states. In Colorado, focusing specifically on Colorado, this is what the Colorado End-of-Life Options Act provides. There has to be a terminally individual with terminally ill, by definition in Colorado, like most places, means a prognosis of 6 months or less. The key is the patient has to be able to self-administer the lethal dose. Patient has to be legally competent. And the law in Colorado authorizes a physician to prescribe the medication to an adult, and only an adult who's terminally ill, so long as he or she has decision-making capacity. The Colorado statute also allows for criminal penalties for tampering with the patient's request for MAID or coercing a person with MAID. A couple of quick facts. In Colorado, the law defines healthcare facility. So if in fact a healthcare facility is a hospital, a SNF, by the way, is a separate healthcare facility. So if you're affiliated with a hospital that has an opt-in policy where medical aid in dying is permitted, the affiliated skilled nursing facility or hospice, even though they're affiliated with a hospital or medical center, would need to have its own policy. Every individual healthcare facility under Colorado law needs its own policy, either opting in or opting out. And having a policy and procedure is really essential, regardless of whether or not an institution permits it or not. At present, NPs and PAs in Colorado are not permitted to provide MAID. Some other states allow that. Some other states are considering allowing NPs and PAs to provide MAID, but at this point in Colorado, it would have to be a physician. And MAID cannot be provided based on power of attorney or guardian or a responsible party. It has to be a competent adult. So if you've got a patient with dementia or cognitive impairment and they lack decision-making capacity, and their guardian or legal guardian or power of attorney says, I want my mother, father, sister, brother, to have this lethal prescription, that won't cut it. That would be illegal under under Colorado law. It has to come from the patient, the adult competent patient. Some of the prerequisites, and I kind of touched on this for Colorado, the individual has to be 18 years old. They have to be legally competent, terminally ill. Both intending physician and consulting physician has to attest to that. Residency is required in Colorado. As I mentioned earlier, Oregon, as of last March of last year, it is not required. And the final requirement under Colorado law is that the patient has to be able to self-administer that. There are documentation requirements in Colorado for physicians. I won't run through all of these in the interest of time because I want to cover some other slides, but it's easy to locate this both in a handout that I've provided or online. Again, having adequate documentation is critical. I've been doing presentations on one thing or another probably for more years than I care to remember, whether I was representing CMS or for the last 12 years representing providers. And I think I always make a point, documentation is key to every case that I've ever had. So I can't overemphasize how important it is to have documentation, particularly documentation about discussion of the alternatives, and clearly documenting that your patient has decision-making capacity. A couple of quick MAID facts. As of last year, this was a little bit dated, but as of last year, there were more than 8,000 prescriptions for a lethal dose written since 1997, when the first state enacted end-of-life options. Of those prescriptions, 6,378 people have died from ingesting MAID drugs. The majority of those patients either had cancer or ALS. 63% of the prescriptions were taken. A huge percentage, obviously, were not. That's been my understanding from talking with folks in hospice, that oftentimes a patient in hospice who's terminally ill, obviously, or they shouldn't be in hospice, will ask for MAID, receive the prescription and the drug from a pharmacy, but they won't necessarily take it. It's a form of insurance for some people in case things get so badly. But again, that underlines why 63% of the prescriptions, not 100%, were taken. The average age of the 6,300 plus people who died from taking a lethal dose was 74 years old, and it's pretty much an equal split between males and females. 87% of the patients were in hospice, 90% of them died at home, and less than 1% of deaths in each state were attributed to MAID. Some of the reasons why patients request MAID, and forgive me, this is probably self-evident. There's a fear, just as Mrs. Daly had, a loss of independence, unrelieved pain, or other physical symptoms. There's a desire to avoid wanting to be a burden to the family, either physically, emotionally, or financially, avoiding the indignity that sometimes accompanies a terminal illness, not wanting to have your family and friends have jaundiced memories of you, the desire to avoid institutionalizations, and to be in control. There's a lot to be said for patient autonomy, which underlines the statute, and fear of losing decisional capacity. Sometimes there are multiple reasons and they can coexist. A key question before I wrap up is, what if you as a physician, even if you work for a skilled nursing facility, hospice, or hospital, where there's an opt-in policy and it recognizes the right of patients to engage in MAID, you have no obligation as a physician to participate in any aspect of MAID. The only obligation you would have if it's your patient and you do not, for whatever moral, ethical, or other reasons, you do not want to participate in that, your only obligation is to transfer the patient's records to a physician, assuming it's appropriate HIPAA disclosure authorization. Your only obligation would be to not withhold the medical records so that the patient could go on and have someone else provide the medication. In terms of the protections, patients can change their mind or rescind their decision at any time, even if they have the medication at home. They're not obligated to take that. As I mentioned earlier, it is a felony to attempt to coerce a patient by anyone, whether it's a healthcare practitioner or a family member or a friend. It would be a felony to attempt to coerce a patient to take MAID. So far, there's no evidence that MAID adversely impacts vulnerable populations, although the statistics indicate that more often than not, those individuals, those patients who seek MAID are college educated. More than 90% of the patients in Oregon who received MAID were in hospice, and this is true in both Colorado and other states. As far as the death certificate is concerned, the cause of death should not be suicide, and it is legally permissible, if not desirable in Colorado, to list the underlying pathology. So if there's metastatic carcinoma of the pancreas or whatever the pathology is, that's the cause of death, not lethal injection. And with that, I see my time is up. There are several slides that I've included that have some excellent resources. And I want to close by thanking all of you for what you do. Whatever your views are on MAID, I respect what you do, and I thank you. As I often say, you men and women are the real heroes for what you do every day. So thank you for that. I think I'm about a minute over time, but as I said, if anybody has any questions or wants any reference material regarding MAID, just email me. I'm happy to provide anything that I can. And thank you very much for the opportunity to present for you folks.
Thank you, Alan. What a great provocative topic. And we appreciate you presenting it so balanced in such a balanced way and giving us all those facts. I know that we don't have a whole lot of time for questions, so we'll direct any questions offline, either by email or to the chat box. But thank you so much for this presentation.
Okay, thank you. Thank you all. Bye now.
Thanks, Alan. Wow. All right, well, we will have to move on from that topic. Big topic. But our next speaker is a big speaker, Dr. Cari Levy, who is the head of the Division of Geriatrics at the University of Colorado. Just before we switch over to Cari, I was just sent this screenshot that we can't let you not see, but Dr. Levy recently had a publication at the JAMA Internal Medicine on the natural history of disability and caregiving before and after long-term care entry. So check that out. Yeah, but thank you, Cari, for being here today, and we'd love to hear your presentation today about Geri Care Everywhere.
Yeah, Sing, are you able to pull the slides up? Oh,
Yeah.
terrific. Thank you. I'm realizing I'm on a different computer today. I forgot the charger for my other one. So lovely to see all of you. And this is a presentation, and I wish we had an hour to talk about MAID. I find it so fascinating. I was in Canada a few months ago, and what's happening in Canada is so fascinating. And we had a family member who presented, and then I promise I'll stop talking about MAID, about her husband who got MAID for fibromyalgia. So there you do not have to have a terminal illness. And it's fascinating. They've had, I think, 33,000 folks receive MAID, and their population is what, a tenth of ours. So it's really accelerating in an interesting way. But we are here to talk about Geri Care Everywhere. So we'll talk about Geri Care Everywhere. All right. And can I advance the slides, or I'll need you to do that, I think?
I think I need to do that.
Okay. There's not a lot of them, but so if you could go to the first slide, that would be great. So I wanted to just give you a little bit of background. This is a legislative effort that was designed to get more folks trained in geriatrics. that hence the name Geri.Care Everywhere. And so it started with Senate Bill 158 in 2021, and this was designed to provide loan forgiveness for folks who are trained in geriatrics. And it is offered through CDPHE. It's for geriatric trained clinicians who are at designated clinics across the state, and essentially those clinics are serving underserved individuals. And they can get up to $40,000 for 3 years for loan forgiveness. So a tremendous help for those who have a lot of loan debt. And so we did that, and then and that's great, but there needs to be, availability of help for more than just physicians. And so the next year, Senate Bill 189 was designed to be more of a pipeline and allow APPs to get some funding as well, and really be a larger effort. We needed to do some tweaking, and so then the successful bill was then advanced in 2023, Senate Bill 31, and that's what we're now calling Geri.Care Everywhere. But the way it got passed was because its title was Improved Healthcare Provider Access for Coloradoans. And of course, who doesn't want to do that? And so Senator Jesse Danielson led this and was a fantastic collaborator on this bill. And so we are now in the throes of trying to get it rolling. And that's where all of you come in, because we would love to make sure as many of you who wish to be involved are involved in this effort. So next slide. So again, it's Senate Bill 31. We're now calling it Geri.Care Everywhere. And the idea is that it's a multidisciplinary provider access training program to serve medically complex older Coloradoans. And while the University of Colorado is sort of administering it, the idea is that we're involving all institutions that wish to be involved across the state of Colorado. And it's designed to expand geriatric training to all of these subspecialty or specialty areas that you see here. So advanced practice providers, and specifically PAs, psychologists, social workers, nursing, including NPs, dentists, physical therapists, occupational therapists, speech language therapists, pharmacists, and also physicians. So we're trying to target all these disciplines and create a core of Geri training that all these individuals will get. And then their individual schools will add the discipline-specific training. For example, for a dentist, I don't need to know everything a dentist needs to know, obviously, but all these folks who go through this program will have this core set of Geri competencies. Next slide. So 9 different specialties across the state of Colorado. And the idea is that we're targeting rural and underserved communities. So for any of you in underserved or rural communities, and if you're interested in recruiting folks who want to be involved as trainees, or you'd like to be a site for experiential training, I would love to hear from you. The idea is that we're going to coordinate with graduates of that program then to be future trainers, so a train the trainer program, and ideally that will really allow us to get kind of an exponential increase in the number of folks who have Geri competencies. As I mentioned, we've got experiential clinical training opportunities, and many of these hopefully will be in rural communities. So please let me know if you fit that bill. And even if you're not in a rural community and you wish to be one of the training sites for these individuals, please let me know. Next slide. And so the proposal right now, so the group just came together, that kind of planning group just came together. And I think there will be some variation across each discipline, but the idea is that everybody who is a trainee in this Geri.Care Everywhere program will be eligible for a certificate in geriatric clinical community care. The VA has put together a really nice training that the GRECs, the Geriatric Research, Education, and Clinical Centers nationally, have come together to do a 5 M's training, and they've got all the competencies, objectives, all the learning pieces of that have been put together by a large, thoughtful group of folks over a couple of years. And we're hoping to pilot that in this grant. And so we're going to use their core as the material that every single person who is in this training program will get. And then we know that folks like, dentistry, social work, want to go on and add additional training opportunities for folks. And so everybody will be eligible for a certificate, and then others may go on to do additional credit hours that will lead to a master's. And this is probably a 30 credit hour program. And so we're kind of letting each school determine how far they want to go. Everybody will do the basics, and then some will go on and do a master's program in geriatric clinical community care. Some of you may be aware that Amos Bailey a few years ago did this for palliative care. And they're now training, I think, 30 people a year, which, our fellowship trains 3 or 4. And they're, training 30 to, I think, 30 people. I think they can go up to 50 in palliative care. And so the idea is that we're trying to help with the critical problem we have with not enough folks who understand geriatrics and are providing age-friendly care. And I think the next one's the last slide. So yeah, just questions about that. So basically the ask today is, if you're intrigued and you wish to have some of these trainees, we will have them about probably starting in October. I think it'll be October when we actually have trainees ready to rock. And initially there will be 2 in each of those disciplines. So 2 speech therapy trainees, 2 social work trainees, 2 in all of those 9 categories that I had listed. We'll get them matriculated. And then once they go through the program, they will have to agree in order to get the stipend to be trainers. And so then they will be part of the, train the training program. And hopefully we can get loads more folks trained up in the basics, the basic 5 M's. So I will stop there and take any questions.
Yeah, I have a question. That's a great idea, Cari. Revolutionary. I'm not surprised. How is it looking in the legislature?
It's passed. We've got money. We got money
Oh.
on station, ready to spend. Exciting.
And
yeah.
is there follow-up for the trainees when they get out in the field? And because this is just the beginning. Because every patient is different, and they don't know. I assume that there's something in the training about when to alert the provider of an urgent situation, and what's the difference between an urgent situation and a chronic delayed referral type of thing, and all that. So I think the follow-up is key, because I'm sure that half of the training will be the trainees' experience implementing this wonderful knowledge.
Absolutely. So there will be the kind of didactic portion for all of these folks, and then they'll be side by side with experienced clinicians for probably a year. So some period of time where they're actually getting that experiential learning and not out on their own initially. And then our hope is that, the rural community that this person was training in then wants to hire them, and that we start getting, some more trained folks out into areas that traditionally haven't had that expertise.
Especially the rural folks. I mean, the hospitals are closing, and
Right.
it's just that they're the people that need it the most. So
Yeah,
that's
no question.
wonderful.
No question. Yeah.
Thank you for your question, Dr. Reitman. And thank you, Dr. Levy, for that update. Wonderful. We'll have to ask any further questions to go directly to Dr. Levy offline or on the chat box, even if you want to.
I'll put my email in the chat. Yep.
Appreciate that. Thank you. And thank you for your comment, Malcolm, that Boulder is underserved. Wow.
Good to know.
Yes. Our next speaker is Dr. Shelley Kahn. She is an infectious disease specialist, assistant professor at the University of Colorado, and the medical director for infection prevention and antibiotic stewardship. I'm just going to share my screen really quickly here so that we can see at least the title of the article that I asked Dr. Kahn to comment on. And it's this article from the New England Journal of Medicine on decolonization in nursing homes to prevent infection and in hospitalizations. And it looked at 28 different nursing homes who were randomized to either regular care or a decolonization treatment for the patients who were getting iodine swabs and chlorhexidine baths. And at the end of the study, which included an 18-week baseline plus an 18-week study period, they were very happy to show that there was a decrease in transfers to the hospital due to infection as part of the decolonization protocol. We thought that was very interesting. And Dr. Khan, thank you for being here today. What is your reaction or some takeaways from this study? If you're talking, we can't hear you. I can't hear you. Oh dear. I can see you moving your lips, so thank you for making the effort. Okay, thanks for working on it. Maybe we can come back to this in a few moments and you can see if there's a different source. And if not, maybe we'll just open up the mic for questions at the end and see what people's thoughts are. Yeah. Thank you for being here, and hopefully we can get some sound so we can hear your expert thoughts. Okay. All right, well, I know that Dr. Fatima Bernard has also joined us, and she is the president of the Mountain West Society for Post-Acute and Long-Term Care. She's based in Salt Lake City, Utah, and basically it's the Utah plus surrounding states chapter of AMDA. And Dr. Bernard has told me about a unique experience that she had in one of her facilities. Dr. Bernard, I'll go ahead and let you introduce yourself and your guest. And I think you said you have some slides to share too. So quiet. Dr. Bernard, Fatima, if you're talking, we can't hear you.
Hi, sorry. I'm here. I'm not good with computers, so I apologize. So I'm very grateful for the invitation and to be here with all of you. I'm happy to share our experience. And as Dr. Pallat said, I'm Fatima Bernard. I'm a certified medical director and medical doctor, and I have Tara Stansworth with me. She's an LPN, ADON, and the respiratory unit manager. And she will do most of the talking of what happened in our facility with this outbreak. So I'm just gonna tell a little bit what C.R.A.B is. If I can share the screen, please.
You should be able to share if you hit the green share screen button.
Okay, that one, I guess. Like this? No. Exit minimize video. There. Okay. Okay. Sorry about that. And I'm there. So.
Oh, looks like you're sharing now. Thank you.
Perfect. Sorry. Okay. So C.R.A.B is carbapenem-resistant Acinetobacter baumannii, and it is a multi-drug resistant most of the time. Actually, the first time that I heard of it was with our outbreak here. It is found in soil and water. Usually, it can cause infections in blood, urinary tract, lungs, and wounds. Most of our patients have that. It can also be colonization. And who is at risk? Patients that have ventilators, catheters, any type of catheters, open wounds, patients that have been in the ICU, and also prolonged stays in the hospital. How is it spread? It can live for long periods of time in environmental surfaces and shared equipment if they are not properly cleaned. So it can be anywhere. Bedside tables, TV, doors, floors, bathrooms, showers, anywhere that a person infected touches, then it's contaminated. It can also It is spread from one person to another through contact with these contaminated surfaces, and also person to person. If you touch a person when you're contaminated, you can also be contagious. And then Tara now will talk a little bit about our outbreak in the facility. Yeah, we're sharing.
Should I talk? Hi, so my name's Tara. I am the unit manager for our respiratory unit. We did have this outbreak on our unit. So patient 0 admitted to us from a well-known Utah hospital on 8/13/22. We were notified by the health department that the resident was colonized with C.R.A.B in December 2022. She was put on enhanced barrier precautions when we were notified of this. By then, the whole respiratory unit was exposed without knowing for 4 months. So our whole respiratory unit was exposed, not knowing that this patient did have C.R.A.B. She didn't have anything in the H&P, no other clinical papers or anything that notified us of that. However, this hospital did report to the health department, which is how we found out that this patient did have C.R.A.B. So we were notified on May 5th, 2023, that the hospital reported several C.R.A.B cases that were sent to them from our facility, as it had already spread. And multiple residents were transferred to this hospital on different occasions. And so they did report those C.R.A.B findings. We received notification from the health department that they would be doing testing of all the residents on 1 East for C.R.A.B, which is our respiratory unit. So we have trachs and vents on that unit. And then we started receiving test results on May 23rd, 2023, where we had 9 residents that were positive for C.R.A.B. They did testing in the groin, armpit, and respiratory tracts. So some of them came back positive on the skin, some came back positive on the respiratory tracts, and some also in the wounds. For patients that had wounds, those were also tested. Education was provided to all the staff, and the entire respiratory unit was put on enhanced barrier precautions, which includes the gowns, the gloves, and high contact resident care activities. We did print out education cards for the name badges for our staff for quick references for what activities they needed to use enhanced barrier precautions. And the high contact activities that we did have them reminding them was if they were going into dress, bathing, showering, transferring, providing hygiene, changing linens, changing briefs, or assisting with toileting. And then device care also with central lines, urinary catheters, feeding tubes, tracheostomies, and vents, as well as wound care. And we did do education with our respiratory therapists and our nurses that they needed to do gown, gloves, face shields, and masks if they were sectioning any or doing any trach vent care for these patients that were positive. So they did, when we first found out about it, they did put the whole unit on enhanced barrier precautions, whether they were positive or not, to prevent the spread on our unit. Residents were not restricted to their rooms or limited from participation in group activities. We did a lot of education on washing hands, staff washing the patient's hands before leaving the room, putting on a gown just so that we didn't contaminate any other places. Like the therapy gym would also, the contaminated residents that were colonized with this, they would take them at the end of the day and do therapy with them and then sanitize the whole therapy area after working with them to prevent any spread of this disease. All residents were tested again on June 12th, 2023. We had 2 new positives. We had 1 more positive on June 21st. Testing on 7/5 were all negative. Testing on 7/18 were all negative on 1 East unit. So then on 7/18, they decided that they needed to test the dialysis patients because a few of our patients off of the respiratory unit were receiving dialysis. They did come up with 1 positive on 3 East, which is a long-term care hall, on July 18th, 2023. Oops, you guys skipped one. Resident family on the long-term care unit, when this patient became positive, we had a resident, the resident's family was very concerned after being notified of the positive for C.R.A.B. that the family would not be allowed to visit or see their loved ones and that they would be isolated to their rooms. This was very upsetting. This family member was in tears. I have the other unit manager here. It was pretty hard to have our staff, our patient and their family member go through this because it was very scary. So we have done a lot of education with staff, family members, and residents on this organism. We had to make sure that the patients maintained at least 3 feet away. In the dialysis bin, in the den, we separated them with barriers, made sure they were 6 feet away from any other residents to prevent cross-contamination. All appointments and providers had to be notified of the C.R.A.B colonization, and many appointments were canceled, which was very upsetting to residents and families. Residents were more depressed and feeling isolated due to having to have staff wear and loved ones wear PPE at all times with them. And then the mental health effects on staff. Staff were stressed out due to taking longer to provide cares related to having to do separate cares, donning and doffing between each patient in each room. And then staff, we were all very concerned about patients' mental health. It was very stressful for us, and we're continuing for health department enhanced barrier precautions. So this unit is indefinitely on enhanced barrier precautions for all residents. So let alone the cost of all of the isolation gear that we go through. So you guys have any questions or concerns or anything you want to ask?
Thank you, Tara, for sharing that experience, an experience, of course, none of us would wish to go through. There are some questions in the chat box. I wonder if I can read them to you. The first one was, were any of the staff screened for C.R.A.B. to see if they got colonized and maybe spreading it?
No, health department was not concerned about that, so they did not have us screened at all.
Oh, interesting. And you mentioned that you had done education for your staff and the residents. Would you be willing to share the education sheet that you used?
Absolutely.
Thank you.
I can send that, I think, via email.
Sure. Yeah, we'll take it. Hopefully we don't have to use it for our facilities anytime soon, but it would be really nice to know what kind of steps you took and what considerations you were making.
Right.
Yeah, thank you so much.
Thank you.
I wonder if we could turn back to Dr. Khan. Maybe you could synthesize all of that plus the decolonization in nursing homes article.
Okay, can you hear me?
Yes, we can. Thank you.
Okay, I know I'm on Teams usually with the VA, and
It's
Zoom
echoing for
may...
some reason, but we do hear you, which is a step up from before.
Okay, how about now?
Yeah, just still echoing, but you can go ahead and give us your comments if you like. Oh, now we can't hear you at all, so. I shouldn't have said anything. Guess we lost you again. I'm so sorry. Don't know what happened. I guess we can't really hear you, Shelley. Give you a couple more seconds. Nothing. I wonder if we want to go ahead and allow one of our...
Oh, I know. Can you
Oh,
hear
there
me
you
now?
are. Oh, yes, we can hear you.
Oh, I'm so sorry, everyone. This
Okay.
is embarrassing because we do Zooms all the time. I don't know what happened. But my name is Shelley Khan. I'm with Infection Control and Antibiotic Stewardship at the VA. We do have a, we call it a CLC, a nursing home here as well. And that presentation was very interesting about the outbreak. That's pretty much our nightmare, I'm going to be honest. So it sounds like you did a great job. I was wondering how you eventually got the outbreak under control.
Yeah, I mean, it sounds like you're on indefinite enhanced barrier precautions. If that counts as being under control, I guess.
Yeah, it sounds like just implementing those surveillance, active surveillance and precautions is what did it. But that is a tough situation. They did just approve an antibiotic, sulbactam, durlobactam, for those very difficult CRAB cases. I just wanted to mention that. But yeah, we can move on to the reason I was asked to talk was just to comment on this new article in the New England Journal about decolonizing nursing home residents. And Singh briefly mentioned the design. It was a very well done trial of randomized clustered controlled trial. And they randomized the groups to decolonization with CHG baths 3 times a week and povidone iodine nasal swabs, and that was kind of every other week and right after admission. And they showed a really nice reduction in transfers to the hospital for infections. So it was an impressive outcomes, and they did say the number needed to treat was like 8 or 9 to prevent 1 transfer to the hospital for an infection. So it was a nice low number needed to treat, but my concerns on this were the feasibility in real life. I checked with our nursing home and they have patients 2 times a week. I hope that's, it sounded pretty good to me basically, but 3 times a week would be adding that additional step. And then the trial noted that only nurses were allowed to do the povidone iodine. And their compliance with that was like 60%. So, again, we're always looking at resources in our CLC, lack of staffing. So some of these things that seem easy to implement can actually add a lot. The other thing is this trial is sponsored by AHRQ, which is good. It wasn't industry sponsored, but AHRQ did provide all the materials like CHG wipes and the nasal swabs. So that would add an additional cost, which those are not hugely expensive, but that is there. The other thing, especially with our population, is we have very long-term residents, and the long-term effects of CHG bathing, I think we don't really know. So that was a concern I had. One of the really good things, just to note, is they did see a reduction on MDRO organisms. And so to speak to the other presentation about outbreaks, I thought that was actually really encouraging, and being in stewardship as well, that could really reduce antibiotic usage if we're lowering MDROs and preventing transfer to the hospital for infection this way. That is really promising. So I guess the summary is I think this is a really well done trial, definitely reasonable to consider. I would look at the baseline incidence of transfer to hospitalization for infections and see if it's feasible to implement at your nursing home.
Oh, thank
That
you.
was a quick 5-minute.
We appreciate that. And it's also your very practical aspects, and those comments are appreciated too. Yeah, thank you. Thank you so much, Dr. Khan. Well, we have a couple minutes for announcements, and we would start with CHCA and then CDPHE. I do apologize for going all the way up to the top of the hour, and I welcome any of you who have a little bit of a few moments to stay to listen to the updates. Jenny, do you have time to stay? I don't know if Jenny is still on. She might have gone. Okay. And then I don't know if Chad. you have some updates for us from the CDPHE today?
Sure. I just wanted to remind everybody, if you're looking for a meeting to go to in January, we are going to have our nursing home roundtable. It'll be on the 2nd. And just a reminder that this will be a hybrid meeting. We are going to finally get back and we're going to meet in person. There'll be the virtual attendance option as well. But we're excited to be able to go back and to meet on campus and see each other in person. Very excited for that. I just wanted to throw out a couple things that I think that we're seeing, maybe some patterns. And that has been in our immediate jeopardy situations involving staff to resident abuse. And in these situations, our concern had heightened because the staff that was alleged to have been abusive was allowed to continue to work with residents. They were transferred to another part of the facility. And unfortunately, in several instances, the abuse continued in another area. So, we do not necessarily expect that staff are going to be suspended during the course of the investigation, but we certainly would expect them to be reassigned to non-resident care responsibilities. Maybe one last thing to leave you with. With the large amount of turnover that has happened in the last 2 or 3 years, and that turnover has continued in nursing facilities, we're seeing some turnover in leadership positions as well. And we've had some recent issues with newly appointed administrators and directors of nursing not being familiar with the reporting and the mitigation requirements around COVID and infectious diseases with respect to testing and the processes that need to be put into place when the facility has an outbreak. And unfortunately, these have led to prolonged outbreaks as well as the increasing spread of the transmission of the infectious disease within the facility. So just kind of throwing it out there, we're seeing a bit of a pattern with this, and it might be a good time to check back with your facilities and see that the infection preventionist is up to date, and that that leadership staff is aware of their reporting and mitigation responsibilities. And that's what I have for you today.
Appreciate that, Chad. Challenging times for sure. Well, thank you to everyone. We really appreciate you joining our monthly meeting. We don't have a meeting in January, but for sure we'll have one in February. So see you then, and happy holidays to everyone. Thank you.